Hello, everybody, and welcome to the GLODERM Training Committee Alopecia Awareness Series. My name is Linda Atten, and I'll be your host today together with Karen. GLODERM Training Committee is a training arm of GLODERM, and that is the International Alliance for Global Health Dermatology. The International Alliance for Global Health Dermatology is an official program of the International Foundation for Dermatology under the International League of Dermatological Societies, ILDS. The mission of the GLODERM Training Committee is to promote knowledge equity by improving access to education for dermatology trainees worldwide. We also aim to provide free educational events and opportunities to build networks and collaborate. September is Alopecia Awareness Month. This month is dedicated to raising awareness for alopecia and all related hair disorders, aiming to increase medical understanding and also the patient impact. This matters because it helps to promote earlier diagnosis, access to patient-centered care, and also supports advocacy for improved treatment options. It supports ongoing education and also evolving therapies and multidisciplinary management. How can you get involved in alopecia awareness? You can participate in our educational webinars and discussions. You can also share your clinical insights and resources with colleagues and also patients. You can engage with patient advocacy groups and research initiatives. You can also promote awareness via your clinics and also social media platforms and any other media platform you're aware of. So for this alopecia awareness series, we have a series of topics which we'll be discussing today. We'll discuss the basics of alopecia diagnosis and clinical cases, treatment trends, and research. We'll also do a live Q&A session. But for each session, of course, we have very notable speakers that will be talking to us and sharing their clinical experiences with us. For the remainder of this webinar, your audios will be muted, your cameras will also be turned off. If you have any questions or comments, please submit it via the YouTube chat function. Our speakers will also answer your questions during our live speaker panel later. I'll also be sharing information about GLODERM Training Committee and how to get involved in the YouTube chat box. Discussing the diagnosis and clinical cases of alopecia, we have Dr. Noureddine from Tunisia. Also have Dr. Mariya Miteva from the US. We will go into dermoscopy and trichoscopy in alopecia. We have Dr. Noureddine Litaiem. Dr. Noureddine is a dermatologist at Charles Nicolle Hospital, Tunis, in Tunisia. He's the treasurer of the Tunisian Society of Dermatology and Venerology. He's also the Secretary General of the African Society of Dermatology and Venerology, ASDV. He's also the past president of the Tunisian Group of Dermatologic Surgeries. Thank you very much, Dr. Noureddine.
Hello, everyone. So I'm Professor Noureddine Litaiem. I'm a dermatologist at the Department of Dermatology, Charles Nicolle Hospital, Tunis, in North Africa, and I'm very, very glad to participate in this global awareness day by GLODERM, and I will be talking today about clinical cases of alopecia. And throughout these clinical cases, I will emphasize more on dermoscopy and trichoscopy. I have also no conflicts of interest to disclose in relation with this presentation. So let's start by the first case. This is a young female patient. She is aged 9 and she complains about this plaques that are present on the frontal and temporal parts of the scalp and that are evolving for several weeks. You see here this alopecia here on the scalp, and remarkably, and the clinical examination showed remarkably that there is no apparent erythema or other sign of inflammation no scales whatsoever, and you only have these oval or round plaques of alopecia. And the hair pull test was positive here. So we take like 30 to 40 hairs and we pull and we see if we have more than three hairs we can consider, the telogen hair, we can consider this as a positive hair pull test. So the clinical examination helps a lot to make the correct diagnosis. And I think many of you have already made the correct diagnosis. But dermoscopy is very, very important as it shows several signs. And I will show you that just now. And also, dermoscopy could tell you when you put your patient under therapy, you can use your dermatoscope to follow up your patient and you see how things are improving over time. But now when you look uh, closer, what do you see? Let's start by examining the scalp first. Here you see that the follicular openings are still there. So there is no disappearance of the hair follicle. So this is a case of non-scarring alopecia. You see some slight pigmentation, and if you look closer, it looks like a network. This is what we call a pigment network. It could be present in many cases of non-scarring or even scarring alopecias, especially in patients with dark phototype. So pigment network here do not have a very important clinical significance. Let's move on now to examining the hair. And you see at the periphery of the plaque, like the normal hair that you see here, and this is the plaque involved by the affected by the disease. So I will I would want you to examine this peculiar type of hair that you see here. So this is the origin of the hair and this is the extremity of the end or the end of the hair. Strikingly, this hair is abnormally short. This is the first thing. And also the proximal part is thinner than the distal part. This is the same thing, but this is kind of a longer hair with the distal extremity that appears thicker than the proximal part. So these two are markers of the same process. In these two hairs, there is an inflammation, though the inflammation is not clinically visible, but there is inflammation that attacks the hair follicle. But as the hair progresses or is growing, there is an inflammation that attacks the hair and makes the proximal part that is more attacked by the inflammation thinner. So this is a marker of the activity of the disease. And this hair looks like an exclamation mark. So we call that exclamation mark hair. And this is like an elongated exclamation mark hair. This is what we call a tapered hair. This is also another tapered hair. This is a marker of the diagnosis. This is a case of alopecia areata. Although we can see elongated and exclamation mark hair in other types of alopecia, here to make things simple, this is for you like a marker of alopecia areata, and it is a marker of disease activity. So when you put your patient under therapy and you see them again during follow-up, and you see that they still have this exclamation mark here, you could imagine that the process is still active and you may need to like proceed with the therapy, or like increase the therapy, or, for example, yeah. And here another type of hair that you see here. This is a type of hair that is regrowing, but it is regrowing fast and not normally, because the regrown hair should move upward. And this hair, as it is regrowing, it is moving like in a circular shape. This is what we call the pigtail hair. It looks like a pigtail, and it is also a sign of a regrown of the hair, but is not like a very normal regrown hair. And I also in my practice show this dermoscopic image to my patient to explain the process of the disease. When I see regrown hair, I tell them, okay, you have hair that is regrown. This is a positive thing. My therapy would lead to more, my treatment that I will be prescribing to you would lead to more positive things, and this would help them with the morale and help them also to keep using the treatment. So dermoscopy could also be used for patients' education and patient follow-up. So this was a case of alopecia areata. Alopecia areata is an autoimmune disease with, as I told you, an increased T cells present in the hair matrix. It could be associated with other autoimmune disorders, and most frequently autoimmune thyroid disease. So you should consider laboratory tests for thyroid disorders in all patients with alopecia areata. And it is a frequent disorder because the average lifetime risk for developing alopecia areata is 1 to 2%. It is very, very frequent in the general population. Clinically, it appears, as I showed you here, as oval or round-shaped plaques of alopecia. And you might see clinically exclamation mark hairs, but to be honest, dermoscopy is very, very useful to show you these signs. And also, as I told you, the positive pull test could be used to see if the disease is active or not. I'm moving now from the hair to the nails, but just to show you that things are associated and interconnected. This is another patient with plaques of alopecia and is coming for seeking medical care for this dystrophy of the nails on both fingernails and toenails. So she reported no poor nutrition, no alcohol use, no joint pain or gastrointestinal signs whatsoever. And here you see the lateral image. You see that the nail dystrophy have this peculiar form with the nail that goes like upward here, and it looks like a spoon. This is what we call koilonychia. So koilonychia was also present in the fingernails and associated also with trichorexis, as you see in those images. So what could be your diagnosis here? Koilonychia is usually a sign of iron deficiency, but this case is an important one that shows you that hair and nail are associated. And the patient had also alopecia areata. And then this koilonychia was a sign of alopecia areata. This case was published in the Journal of Clinical and Aesthetic Dermatology. It could be accessible. It is open to be read by every doctor. And you can read this article if you want. And the patient was treated by both topical and oral corticosteroids because we considered that her alopecia areata was very active and kind of severe, and also the existence of nail involvement is a sign of poor prognosis. So this led us to treat her very actively with both topical and systemic therapy, and this led to great improvement of both hair disease and also the nail disease, as you see here. I showed you this case because it is important to notice that hair and nail are associated. And I will go through other cases in my presentation that showed you that you need to examine the hair, the nails, and also the mucosa and the skin for a complete examination of the patients. So as I told you, the prognosis of alopecia areata depends on many things. A long-standing disease is very difficult or more difficult to treat than a patient that comes like with the alopecia for 2 or 3 months. It's easier and we obtain better results when we treat a recent disease and an active disease, but a long-standing disease is more difficult to treat. Also, nail involvement is of poor prognosis. When alopecia involved all the scalp, that's what we call alopecia totalis, or all hair in all the body, that's what we call alopecia universalis. These are also signs of poor prognosis, and there is a peculiar form of alopecia areata that involves the band on the occipital region that we call ophiasis pattern. This is also associated with poor prognosis. Let's move on now to the second case. This is also a young patient, but a male patient. Different from the first case that the plaques do not show on the first case any signs of inflammation or scales. Here we see scales and slight erythema, that is a marker of inflammation. So clinically the diagnosis is also easy, but dermoscopy, I will show you dermoscopy, is very striking. Here you see that there is a slight erythema on dermoscopy, also some pustules, signs of inflammation. But strikingly, you see very obvious dystrophic hairs. Many are cut some millimeters after their emergence, as you see here. So we have several types of dystrophic hairs. Those here cut very short, that look like black dots, and we call that black dots. Some hairs that are broken at several parts that look like a zigzag, and we call that zigzag hair. Another one's also present throughout this image. And you have also these bands that look like less pigmented in a hair that is pigmented, that give this Morse code hair that you see here, here, and here. So all these are signs of tinea capitis. And the diagnosis of tinea capitis is pretty straightforward when you put the dermatoscope. One peculiar sign is these hair that look like a comma, that we call comma hair, is very also very suggestive of the diagnosis of tinea capitis. So this was a case of tinea capitis, and it was confirmed, of course, after mycological examination. Tinea capitis occurs more frequently in children. Why children? Because adults are kind of like normally protected by the increased production of sebum that halts or represses the development of fungus. So it occurs more frequently in children, but we can pose a diagnosis of tinea capitis also in adults. It is possible. In Tunisia, the most frequent cause of tinea capitis, or the most frequent pathogen, is a microsporum canis. It is not the same in other parts of the world. For example, in the United States and the United Kingdom, it's Trichophyton tonsurans who is responsible for the majority of tinea capitis. And trichophytic tinea are more difficult to diagnose. Here is a case of microsporum canis or microsporic tinea capitis, very obvious, straightforward. You see these large plaques of alopecia with scales. But in trichophytic tinea, you might see patients, young patients with like seborrheic dermatitis like scaling. And the idea here, in every young patient with scales, seborrheic dermatitis like scales on the scalp, you need to examine them very, very well clinically and using your dermatoscope to see if they have signs of trichophytic tinea. It's very, very important because trichophytic tinea are not easy to diagnose. The plaques are usually smaller. The hair are broken very early, and when you put your dermatoscope, you mainly see the comma hairs. So the wound lamp examination is usually normal, but you need to be careful. And also trichophytic tinea are transmitted from a human being to another one, so the transmission enter humans, but this case of microsporum canis related tinea are transmitted from animals to human. So be careful of trichophytic tinea because it appears in small epidemics in schools, for example, and it's transmitted entre human. So it is very, very important to diagnose the patients and to see if there are contacts that have the same thing and to treat them carefully. And here in this paper that we published many years ago, around more than 10 years ago, we explained that the epidemiology of tinea capitis is evolving, it is changing. And here we took the example of Tunisia. So in Tunisia, for example, in the early 20th century, we had only trichophytic tinea. But now trichophytic tinea nearly disappeared. We only have, so the epidemiology went down. We have less and less cases now, and virtually the only cases of tinea capitis that we have are related to microsporum canis transmitted from cats and dogs to humans. There are also cases of inflammatory tinea capitis, rare, but you might see also those cases, especially in rural areas, because these cases are transmitted from animals to humans mainly. Let's move on now to the third case. So this is a patient. This is a female patient, aged 19, that she complains about alopecia, but different from the two cases that I showed you earlier, because there is no plagues of alopecia. The alopecia affects the vertex. In this patient, there is a rarefication of the hair with no real plagues here. So could you make the diagnosis based on naked eye examination? To be honest, it is difficult. So the dermoscopy here is paramount, and it helps a lot because when you put your dermatoscope, what is striking in this case is to see that there is hair with different caliber. Here, hair with normal like caliber. Here, for example, thinner hair here, very thin hair. You see that the width of the hair is different. And it affects more than 20% of the hair that appears thin. This is what we call anisotrichosis, and this is the marker of androgenic alopecia. So this patient have androgenic alopecia. Of course, there are other signs but I'm not going into details. And one of the other signs is the predominance of hair follicles with only one hair, because normally we in a hair opening we have 2 to 3 hairs that are should be visible. Here we have a predominance of hair follicles with only one hair. So this is another sign of androgenic alopecia, and there are more. But keep in mind the hallmark, the hallmark of of androgenic alopecia is uh, the anisotrichosis. The fact that the hair caliber is not the same and that it affects this different in width affects more than 20% of the hair follicle. So this is what we call also male or female pattern hair loss. It affects many men, and especially in the elderly, more than 80% of the Caucasians aged 70 or more have androgenic alopecia. So it is related to sensitivity of the scalp to androgen hormones. To make things simple, like androgen aromorrhea produced after puberty in both males and females, and like this androgen give the odor to the hair in the and this part of the hair follicle of the scalp to for the hair to become thinner and then to disappear. So this is what we call the miniaturization of hairs on the frontal, midline, and vertex regions in men, and at the midline and the crown in women. And usually in women, we have like this frontal hairline that is spared, and this is also a sign that would help us make the correct diagnosis. So androgenic alopecia may be associated with telogen effluvium. Telogen effluvium is when the many hair that becomes like synchronized and goes to the telogen phase. So this increases the perceptance by the patient that they are losing hair. At this time, they may seek medication. It is very important to exclude hyperandrogenism in patients with androgenic alopecia. And the treatment is mainly based on minoxidil for both genders, and we can like use oral or topical minoxidils. This is not the main topic of my talk, and I am sure that you will be given more information on the therapy. This is an image, dermoscopic image, just to show you the difference between telogen effluvium here and androgenic alopecia. Keep in mind that androgenic alopecia and telogen effluvium could be associated, but in telogen effluvium you have normal hair. You have only like rarefication of hair, predominance of hair follicle with only one hair, and like openings, like empty openings of the hair follicle. But we don't see here anisotrichosis in telogen effluvium. Let's move on now to the fourth case. And here what is different is that we have the disappearance of hair follicles in some parts of the scalp. So we have here a case of scarring alopecia. When you put the dermatoscope, what's striking is the inflammation. But I wanted to show you that the inflammation affects the area around the hair, but also the skin between the hair follicle. This is very important for this peculiar kind of diagnosis. And here the same patient, but the dermoscopic images is taken elsewhere in the scalp. You see this hair follicle with opening filled with keratin, as you see here. You see this follicular opening filled with keratin, and you see the disappearance of the hair follicle, as you see here. This yellow dots are very important for this peculiar kind of diagnosis. The same patient have also lesions on the skin, and you see the same thing. The follicular openings on the skin also are wider with these yellow dots that you see here, because you have like the follicular open filled with keratin. We have this follicular plugs histopathologically, and there is inflammation, and in long-standing plaques you have this scar as you see here. So this was a case of cicatricial alopecia. So cicatricial alopecia is defined by hair loss of hair follicle with scarring. Keep in mind that non-scarring alopecia, like androgenic alopecia or alopecia areata, could result in permanent hair loss. So there is an emergency to treat those cases. So the patient that I show you was a case of discoid lupus erythematosus. And the dermoscopic images I showed you both like recent plaques and also long-standing plaques. But keep in mind that treatment is paramount, because when you treat in an efficient manner the patients, you may prevent the progression of alopecia. You may even have like this some regrowth of the hair, as you see here. This part of the hair, you have like slight regrowth of the hair. So it is very important to treat effectively discoid lupus erythematosus, because you could save some hair follicle and save them from the existence of long-standing alopecia. Now my fifth and last case. This is a female patient aged 50. She had this frontal alopecia here, with this peculiar aspect of lonely like terminal hairs here, very suggestive of the diagnosis. And when we examine the axillary, she has region, she has also alopecia here. When you put the dermatoscope, you see the disappearance of hair follicles. So this is also a case of scarring alopecia, but the inflammation, although slight here, is predominant around the hair follicle. This is a sign that we see in lichen planopilaris and also in frontal fibrosing alopecia. This was a case of frontal fibrosing alopecia. The disease was described quite recently in the 1990s, but it is now the first cause, the most common cause of cicatricial alopecia. So you need to know that. And it typically leads to a regression of the um, frontal part of the hair here, and it leads like a band with alopecia and no hair that affects the frontal part and occipital part. There are many other signs that could be associated, but the inflammation in dermoscopy affects the the hair around the hair. This is very, very important, and the skin between the hair follicles are not affected in comparison with discoid lupus. So with this case, I'm coming to the end of my presentation. I thank you very much for your attention, and I hope that you find this Global Awareness Day very useful and informative. Thank you very much.
Discussing histopathology in alopecia, we have Dr. Mariya Miteva. Dr. Mariya is a professor at the Dr. Philip Frost Department of Dermatology and Cutaneous Surgery at the University of Miami Miller School of Medicine in Miami, Florida. She's a dermatologist and dermatopathologist with special expertise in hair disorders and hair pathology and trichoscopy. She authored several books, including the first book dedicated to correlating trichoscopic pathology titled hair pathology with trichoscopic correlations. She also has numerous scientific publications. Thank you very much, Dr. Mariya. We are very glad to have you here. Thank you for honoring our invitation to be here.
Hello everyone, my name is Mariya Miteva. I'm a professor at Dr. Philip Frost Department of Dermatology. My main interest is hair loss and hair pathology. Today I'm going to talk about histopathology of alopecia. My objective is to educate you about the value of histopathology in the diagnosis and management of hair loss and show you the usefulness of utilizing horizontal sections when we perform biopsies to diagnose alopecia, and also to demonstrate the power of the trichoscopy pathology correlation for the management of alopecia. I have no relevant disclosures to this presentation. So this is a simple procedure, the scalp biopsy. We do it every day in the clinic. We use a 4 millimeter punch biopsy, very rarely a 3 millimeter. And when we take the biopsy, we rotate the punch clockwise and try not to cut the tissue too much by cutting the edges of the specimen so we can get a good specimen to the lab. And we put usually 1 or 2 stitches to achieve hemostasis. So we utilize the Haddington technique. This is a technique in which the specimen is bisected in the horizontal or the transverse plane about 1 millimeter below the dermoepidermal junction or about 1.5 millimeter below the surface, and the two halves or the two parts of the specimen are inked, and then they are embedded with the inked side in the same cassette. So when we do serial sections, in one direction we arrive more towards the surface and in the other directions towards the subdermis in order to assess all the levels along the hair follicles. So horizontal sections are very helpful to assess the follicular architecture, and this is crucial. The main thing when you begin examine the specimen, you want to decide if you're dealing with non-scarring alopecia in which the follicular units and the architecture is preserved, or you're dealing with scarring alopecia in which there is a drop of follicles and sebaceous glands replaced by fibrous tracts or fibrotic tissue, as you see here on the pictures with the corresponding trichoscopic images. So the optimal processing, it's usually, like I said, about 1.5 millimeter below the epidermis, and then we basically cut it to the transverse plane, and we cut about 20 sections, 25, usually sufficient to make the diagnosis if the specimen is properly bisected. You see that in this case, if you look at the lower diagram, the more we cut towards the upper half, we arrive to the infundibulum where the follicles actually exit, the hair exits from the follicles at the surface, and the more we cut down to the subdermis, we actually observe the bulbs in the fat. In this way, in the horizontal sections, we are able to assess the morphology of the hair follicles from the subdermis, where the bulbs are located, to the infundibulum, where the hair shafts exit the surface. This creates a more complex overview of the morphology of the hair follicles. So horizontal sections are crucial to make the diagnosis in non-scarring alopecia. As you see in this example, at the level of the isthmus, we can observe the follicular units organized in these hexagonal structures separated by connective tissue, and we can assess the follicular architecture and perform counts. Whereas on the specimen on the right, where you see only the vertical sections, we can only take a guess because we can only see a few follicles. So this is representative images from the different levels. The pathologist needs to be familiar with the architecture of the hair follicles at the different levels and be able to perform follicular counts and ratios, which are crucial for the diagnosis of non-scarring alopecia. So this is a good example of a specimen, which in this case is showing the level of the isthmus. You see the different follicular units. Basically, these are structures which are composed of terminal follicles, 3 or 4 with one vellus follicle, and the associated sebaceous lobules. And you see how they're separated by the connective tissue. So in this case, I can perform the follicular counts and ratios. I can come up with the numbers and basically establish a complete report for the diagnosis, which in this case is androgenetic alopecia. So the normal density of the follicular units is usually 12 to 14, sometimes 10 in a 4 millimeter punch biopsy, or 1 per square millimeter. We usually utilize 4 millimeter punch biopsies in the clinic because all the follicular counts and ratios are established for 4 millimeter punch biopsies, and they have more 5.6 square millimeter more tissue versus 3 millimeter punch biopsies. That's why we prefer to use 4 millimeter punches, especially for non-scarring alopecias. I would do a 3 millimeter punch biopsy at the hairline to be cosmetically more sparing in cases where I suspect frontal fibrosing alopecia as an exception. So let's look at some classic examples. We're going to start with telogen effluvium, which is a very common diagnosis in the clinic. And in this presentation, I'm going to focus on trichoscopy and pathology, and will not be showing clinical images, which will be covered in different presentations. So it's very important for the pathologists, but it's also important for the clinicians, and I'm a clinician myself, so I know that from firsthand, to be familiar with the counts of the follicles in biopsies from normal scalp, in telogen effluvium, androgenetic alopecia, and alopecia areata incognito, common diagnosis which we see in the clinics. And as you can see here, they differ in the ratio and the counts. So in telogen effluvium, we really don't have specific trichoscopic features. Trichoscopy is a tool which is basically a scalp and hair shaft dermoscopy, and it's very useful in the clinic. I utilize it every day on my patients. In this case, you see no hair shaft variability. You see short regrowing hair, sometimes empty dots. If we take a biopsy, the biopsy in chronic telogen effluvium is indistinguishable from normal scalp because we have a normal organization of the follicular units, as you see in this specimen, and we don't have increased number of vellus follicles, so we have normal terminal to vellus ratio. We have also normal number of the telogen follicles. We would have increased telogen count in acute telogen effluvium. So sometimes we would see mild perifollicular inflammation. You can see that in telogen effluvium, in androgenetic alopecia, and as well as in normal scalp. So this should not be called or misconcluded as scarring alopecia right away. What about alopecia areata? This is a diagnosis that we make clinically, and trichoscopy is very important in the diagnosis of alopecia areata. As you know, it goes through different stages. We have acute stage, we have subacute stage with the persistent patches, and chronic stage, which is usually more than 12 months of long-standing no regrowth. And the different stages have different trichoscopic features, as shown here on the picture, and different histologic features. What is important is to remember that not always alopecia areata pathology should be associated with the swarm of bees. This is a characteristic finding only in the acute or the active stages of the condition. So, as I mentioned, trichoscopy is very useful when you see broken hairs, black dots, exclamation hairs, and here you see yellow dots. This is very useful, pointing towards the diagnosis of alopecia areata in the right clinical setting. And on the lower picture, you see some short regrowing hairs, circle hairs, in which case the patch is trying to recover, to regrow, but is not there yet. What about pathology? In acute or active stage, as I mentioned, we would see this increased telogen count, and we see the classic swarm of bees infiltrate, which is basically T helper 1 type lymphocytes invading the follicular matrix, which leads to abrupt catagen telogen shift and weakening of the hair shaft, and therefore you have hair breakage at the surface, or the hair doesn't even come out. The swarm of bees infiltrate is very easy to recognize because we will be looking in the subdermis around the bulbs, and the lymphocytes are surrounding the bulbs, the matrix you see here, or even invading the matrix of the hair follicles. In subacute stage, remember, we will not see the swarm of bees, but we will see increased telogen count as shown here on the picture. You see the telogen hairs, they lack the hair shaft, and they undergo what we call volumetric reduction of the outer root sheet. They look like these leaves. I like to resemble them to these leaves on biopsy, and you can also start seeing some more miniaturized hairs. And in chronic stage the stage that, for example, patient has alopecia universalis or has patches that have not been growing for a while, you will see this non-cycling fibrous streamers where there's no action of recovery of the anagen follicles, and you will see also absence of follicles. If you have less than 1 follicle per square millimeter, the prognosis may be poor for regrowth. But you see here we find no swarm of bees infiltrate and no telogen follicles. It's a chronic stage. And I'm showing you here a picture of cutaneous lipoatrophy, which is not uncommonly seen in the clinic after injections with steroids. You see that there is the fat, the subdermis shows shrunken lobules. The lobules become smaller. The fat cells or the adipocytes become smaller in size, and you see this increased number of vessels. This is rarely biopsied, but it's also important to be for the pathologist to recognize in biopsies. Now, this I want to draw your attention. In young children and sometimes in elderly patients, we may not see these yellow dots on trichoscopy, which refer to the dilated infundibula plaqued with sebum. And we may think, oh, this is scarring alopecia because we only see loss of follicles. But this is not true, because remember that in prepubertal children and also in elderly patients, we have atrophy of the sebaceous glands, or respectively the sebaceous glands in young children are not mature because there's no hormonal stimulation. So we lack this yellow dot. So do not get confused. And in such cases, if you're not sure, do the biopsy, but do not label these patches as scarring alopecia. Okay, I will show you a few examples. This is a patch a patient had for 1 year that was diagnosed and treated with a type of light called excimer laser, as you know, and steroids for alopecia areata, but the patch was not improving. And when you look on dermoscopy, here you see these keratotic brown dots. This is very important. You have to take a biopsy in such case, because this is not alopecia areata. When you take a biopsy, you realize that this is a different condition, and this is a classic example of lupus on a biopsy from the scalp in horizontal sections. We have very dense interface lymphohistiocytic infiltrate and plasma cells. You have pigment incontinence, and we have increased number of telogen follicles. So this is an example of lupus. And I wanted to show you, this is another dermoscopy from a different patient with a patch similar to the one I showed you, which actually showed lupus paniculitis. So when you see this brown dots, if you see these arborizing vessels, like in this case, you want to take a biopsy because it could be a patchy form of lupus. Alopecia areata incognita is when patients have acute diffuse generalized hair shedding with unknown trigger, no patches. Sometimes they have a history of patches in the past, no dystrophic hairs on trichoscopy, and many times if you do the pool test, the pool test is positive for early telogen club hairs. And I'm just showing you a nice example of a patient who improved significantly with topical minoxidil and with topical clobetasol. And after 3 months of treatment, you can see before and after how much of the hair has regrown. So it's a very good prognosis. In such cases, you can take a biopsy, and the biopsy shows basically usually association with androgenetic alopecia, or at least borderline miniaturization. You have increased telogen count about 30%, which is significantly more than the normal count, up to 15% in scalp biopsies. And you have an increased number of these small telogen follicles and telogen germinal units, which are presented here on this slide. So in such cases, it is important to take a biopsy because you can reassure the patients that they have a good prognosis with the right treatment. In many cases, in alopecia areata incognita, we see this dilated infundibulum. Very commonly, we see those also in alopecia areata, but in alopecia areata incognita, like in this case, they can simulate even the Swiss cheese pattern with the holes in the cheese. What about androgenetic alopecia? This condition doesn't need introduction. It's the most common alopecia we see in the clinic. And so I will only mention that there's excellent clinical, trichoscopic, and pathological correlation. We see follicular miniaturization on the biopsies. Usually the terminal to vellus ratio become less than 2.2 to 1, but there is a gray zone between 2.2 and 4 per 1, which is basically initial miniaturization. So you can see here in the biopsy increased terminal decrease terminal hairs and increase vellus follicles. Same here. And same here. It's very important if you think to look at you if you think your patient has androgenetic alopecia, to ask for symptoms on the scalp. Sometimes they have ill-defined itch. You take your dermatoscope, look at the scalp, and if you see this peripilar cast, you have to take a biopsy, because this could be a presentation of what we call fibrosing alopecia in a pattern distribution, or combination of lichen planopilaris and androgenetic alopecia. Okay, this is the pathology. In such cases, I will always take a biopsy, and the biopsy shows me here what? Apart from the miniaturization or increased number of vellus follicles, we have perifollicular fibrosis and lichenoid lymphocytic infiltrate. So these patients should always be biopsied. Okay, just very briefly about other non-scarring patchy alopecias in the clinic. How about this case? We have these large irregular yellow dots in a patient with patches on the scalp, and we have these arborizing vessels. So this has been described as a red spider over a yellow dot, thin arborizing vessel emerging from the center of a big yellow dot, and corresponds to the diagnosis of lupus erythematosus. So remember, you can have patchy alopecia in lupus erythematosus, many times misdiagnosed as alopecia areata, usually in severe systemic lupus or patients who flare. They have lupus and they flare, they present with these patches. It has very good prognosis. They completely regrow the hair with the right treatment. On pathology, this is not alopecia areata. Why? Because we have deep periodontal inflammation. We have so-called lymphoid follicles, and look how we have also interface dermatitis. So this is the picture of lupus. And the patients have complete regrowth with the arresting of the flare. What about trichotillomania? Usually you don't need to biopsy. And keep in mind that some patients have trichotillomania and alopecia areata. It's not uncommon in children. But in this case, with trichoscopy and clinical exam, you diagnose the patient because they have different kind of dystrophic hairs and hairs broken at different lengths. You can see here flame hairs, all kind of morphology of twisted and traumatized hair by the trauma on the hair shafts. So if I do a biopsy, the biopsy is really, the histopathology on the biopsy is really easy to distinguish from alopecia areata because we see these features of trichomalacia. Basically, the hair shafts are distorted, they're traumatized, and they're not intact anymore. They have all these clumps of black dots. Basically, this is the pigment from the cortex of the hair shaft, which is referred to as pigmented casts, and they can come in different shapes, usually comma shape, button shape, zip shaped, and this makes the diagnosis. These patients also have increased catagen telogen count in the biopsies because remember that if there is an insult or trauma on the hair follicles, they will shift into catagen telogen. You can see here this peculiar shaped pigmented casts. Now we're going to talk about scarring alopecia, and biopsies are crucial, or they're the golden standard in the diagnosis of scarring alopecia. What do we see in scarring alopecia? We have decreased number of follicles and their associated sebaceous glands because we have the follicles and the sebaceous lobules being replaced by fibrotic tissue, which we call follicular dropout. Look at here on the image with the arrows. I highlighted for you pre-existing follicles that have been replaced by columns of fibrotic tissue. This results in an altered follicular architecture, which will be much easier to appreciate on horizontal sections because you will be able to assess the whole architecture through the transverse plane. One very important thing is that in the clinic you should use dermoscopy to guide the biopsy site. So the idea is that it's like using imaging to guide the best site when you take an organ needle biopsy. You want to take it from the best possible site where the pathologist can yield the diagnosis. And we have published in the past a very instructive paper, and there have been subsequent number of papers commenting and highlighting where to take the biopsy from. But in a case like this, look at this image, I would spot the peripilar cast in this picture, in this exam, and then I will circle around it because I know that if I go for the hairs that form like mini tufts surrounded by this cast or scale, peripilar cast, I have a higher chance to make the diagnosis of scarring alopecia. And it's very easy to spot the affected follicles by inflammation and fibrosis if you apply the owls and the goggles rule sign. So basically, I will show you on the next example. These are follicles that merge together by the fibrosis and the inflammation. They just this corresponds to these mini tufts of and real tufts of follicles. Look at here. We have an example. We have a picture where we immediately can tell that this is scarring alopecia because the normal architecture is distorted. There is no sebaceous glands and follicles organized in follicular units, and the majority of the follicles and sebaceous glands have been replaced by scar tissue. You immediately spot the goggles in this example, and basically these are follicles surrounded by perifollicular fibrosis or fibroplasia and some mild lichenoid infiltrate in this case. So look for these structures at the isthmus level and below because you don't want to get confused. In the upper level at the infundibulum, you can have this, which I call pseudo goggles, because the follicular infundibula usually represent 2 or 3 hairs merging with the outer root sheaths coming out together at the surface, which is a normal finding. But remember, there is no fibrosis and no inflammation. And so let's look at some examples. In lichen planopilaris, for example, we can see here this peripilar cast, loss of follicles, broken hairs, inflammation or perifollicular erythema. This is where you want to take the biopsy. Again, remember, you don't want to biopsy a scar tissue. You want to biopsy an area where you see the peripilar cast and you see this mini tufts. This is the area that is going to the pathologist, the best possible site to make the diagnosis. And then it's easy on pathology. We see this perifollicular fibrosis, the lichen node inflammation. We can say this is a diagnosis of lichen planopilaris. And again here, look at the infiltrate affecting the bulge where the stem cells reside in lichen planopilaris. The sebaceous glands are actually early on affected in scarring alopecia, and they get inflamed and destroyed together with the follicles. Another example, sometimes the inflammation is really strong, like in this case, it's more like interface, so the lymphocytes really attack and go within the follicular epithelium. Okay. Frontal fibrosing alopecia, which many consider subtype of lichen planopilaris, on pathology is almost identical and many times impossible to recognize without clinical information. I am showing you here our upcoming CME article on FFA in the Journal of American Academy of Dermatology for more information. But I'm going to show you some examples. In frontal fibrosing alopecia, remember early on, the patients lose the vellus or the baby hairs on the hairline. And you can see here that the difference with the normal hairline is also the loss of follicles and the inflammation around the lichen node inflammation with fibrosis around the affected follicles. So in such cases, it's good to take a biopsy to confirm the diagnosis, especially if it's early case and you are not sure. Again, dermoscopy guided biopsy. So many times in FFA, we see this vessel network. Why? Because the skin is thin or atrophic, and basically if you use your dermatoscope, you see the ramifications of the superficial vascular plexus very close to the surface, highlighted. And there is atrophy. Why there is atrophy? We did a study and showed that the epidermis and the dermis in frontal fibrosing alopecia undergoes atrophy. And you know how patients have these prominent veins that you can see through the skin and other features. So in biopsies from the limbs or the extremities, you know they can be affected, they can show alopecia. Remember, there is no perifollicular fibrosis, but the hair loss is permanent. In CCCA or central centrifugal cicatricial alopecia, is also very important to take a biopsy because you can confirm the diagnosis versus traction alopecia, which can be very difficult in a patchy subtype of CCCA, and also you can assess for inflammation and for progression of the scar tissue. So you want to take a biopsy from these hairs that show the peripilar white-gray halo, or broken hairs is also a very good site to take the biopsy, where you identify the affected follicles. You see that again, the drop of follicle sebaceous glands, and again this perifollicular fibrosis, which usually milder than shown on this picture, lichenoid lymphohistiocytic infiltrate. And many times you see this fragmented hair shafts is very common. You see again the goggles, very easy to spot in scarring alopecia, especially on low power. So what about discoid lupus? In discoid lupus, remember the patch shows a lot of this prominent thick arborizing vessels within the patch. They're even like monstrous vessels. And in lichen planopilaris, the vessels are more linear and they're at the edge of the patch. You can see this follicular red dots, which basically is a lot of inflammation with red blood cell extravasation around the affected follicles. They're considered specific for lupus. And you see a lot of sometimes blue-gray speckled dots, which is the pigment incontinence. The biopsy is not difficult for the pathologist because, like I showed you before, it shows interface dermatitis of the follicular epithelium with pigment incontinence, thickening of the basement membrane. If you stain for mucin, it's usually very positive in an interstitial type of pattern. Here are some classic features. So on horizontal sections, we usually perform the diagnosis on horizontal sections. It has been shown that there are two subtypes. One, or early on, mimics alopecia areata because of the dense inflammatory infiltrate in the subdermis and the shift to telogen. And the less common one mimics lichen planopilaris. Some examples here, alopecia areata-like pattern. This is more, in my experience, more common in early cases, and they may have good prognosis with some regrowth. And this is the lichen planopilaris-like pattern where you see this perifollicular, very fine lamellar fibrosis. Usually there is no perifollicular fibrosis in lupus versus LPP. Here you see the keratotic plaques. Again, the keratotic plaques, very nice correlation trichoscopy pathology on this example. And what about folliculitis decalvans? It's a rare condition in the clinic and is very striking on a clinical and trichoscopic exam because you see the tufts of hairs, usually more than 6 hairs coming out together, surrounded by this very thick scale. And the scale basically, when you melt the scale with some gel, you can see the vessels in the starburst pattern. On pathology, the diagnosis is not difficult because we identify this so-called polytrichia or compound follicles. So many hair shafts in this case, at least 6 or 8 sometimes, they merge together and they're surrounded by this perifollicular fibrosis and very dense lichenoid and interstitial mixed cell infiltrates, neutrophils, plasma cells, lymphocytes, and eosinophils. That makes the diagnosis of folliculitis decalvans. This is my last slide. Thank you very much for your interest and your attention. I would like just to highlight that the trichoscopy and pathology go hand by hand in the clinic, and this is my book that you can read more about both in different hair disorders. It was my pleasure to give this talk.
Thank you very much. You can follow us on all our social media platforms to learn about upcoming events, webinars, programs, and more. And you can also get involved with us by being a member of GLODERM by scanning at the top right-hand corner. Thank you very much and have a lovely day.